lunch dip. Everybody starts to fade. So please feel free to stand up, move around, stretch, do whatever you need to do, okay? Let's talk about the problem areas in detail. So, as a reminder, interpersonal role disputes, which essentially means that there's a difficulty in expectations, meaning that two parties don't have the same expectations for the relationship, and it often leads to frequent conflicts. Interpersonal deficits often is around a person who's lacking communication or social skills, needing to initiate and maintain relationships, and it can lead to a paucity of social relationships and social withdrawal. Interpersonal role transitions, which is when a patient is struggling to adjust to a new phase of life or a new role. So common examples are retirement or parenthood or divorce. So major life transitions, graduating college, first job, those sorts of big life transitions. And grief, so grieving a loss of a significant person. And again, I'm using loss here to encompass not just death, but the loss of an important relationship. And I mean total loss. And then life goals, which would be feeling at sea with your sort of general life goals. Like you don't really know what the patient's going to do for a career. They're not maybe progressing along the trajectory of developing relationships and a family, even though they want that. So that's sort of just at sea, failure to launch type of example. So we're going to take these step by step. So first is role disputes. So the onset or maintenance of the eating disorder is associated with an unsatisfying interpersonal relationship characterized by non-reciprocal role expectations between the two parties. So let me just tell you that when I first learned about the role, or the interpersonal problem areas, I didn't get it. I mean, I really just blankly didn't get it. I couldn't quite conceptualize it. But when you sit with enough patients, it's sort of, and you have this framework in mind, people sort of filter themselves into the categories in a way that starts to make more sense. So if you don't leave here feeling 100% confident that you can decide between problem areas, know that if you go into an IPT for eating disorder treatment with someone and you have the baskets in your mind, your clinical expertise will help them filter where they go. And that as long as you and the client are on the same page, then go with it. So is it, and maybe 2 sessions in, when you think you're dealing with a role dispute, you realize that that whole role dispute is because of parenthood. You know what? Let's switch gears. This is really about a transition. And just say that and do it. So it's not, you don't have to be a magician. You have to be real and be communicating with your client about what feels right. So this is really important about the role disputes in particular. I think this is perhaps the most important one because, first of all, we see a lot of role disputes. If you work with adolescents, you see a lot of role disputes. And the role disputes can show up in sneaky ways because they don't have to be active arguments and disagreements. I think 2 primary times of life when role disputes are most common are adolescence and long-term marriage. Role disputes around adolescence is often with a parent, and they just have sort of stopped talking about it, or sort of like what Jamie was doing with that patient. The daughter wasn't actually communicating to her father what she wanted, right? So they had sort of stopped talking about it. She assumed he didn't want to spend time with her anymore. He didn't know, he was none the wiser. They just weren't talking about it. That happens in long-term marriages too. So there can be things that just feel like we've been there 1,000 times, we just agree to disagree, but it's sort of still gnawing at someone. And so they're at sort of an impasse, and they can be not actively talking about it. So when you're thinking about role disputes, it doesn't have to be big blow-up arguments. It has to be different expectations. I want to spend more time with my dad, he's not giving it to me, but I've never said that to him and he doesn't know that. So that's still a role dispute. Often the patient doesn't think the dispute could be resolved. If they thought the dispute could be resolved, they would try to resolve it. So our job is to help them see it differently, help them start to think about it, like maybe I can make some inroads here, and to give them new skills. So to say, you know, I know you've had this argument, what seemed like 1,000 times to you, but now you're about to have this conversation armed with all these new skills and tools. And so this is a different conversation, right? The tone of it has changed. And so you sort of set up a new framework around an old conflict, and that can sometimes help people feel like they have the tools to make it different or to do something different. So again, disputes can be obvious, as when people openly argue. They can also be hidden about what they don't argue about, and the issue feels distant and sort of cold. So there are a couple stages of disputes, and I think this is really helpful just to know in any type of treatment that when people are in conflict, that there's sort of 3 phases. So first is a renegotiation. This is usually when there's a lot of arguing, so people are sort of trying to figure out what role they play and try to figure out if there's a resolution. If a client is in that phase, they're usually really open to talking about strategies to communicate differently. But more importantly, what we more often see is the impasse. So we see times when the discussions have stopped and there's just this smoldering, low-level resentment going on, or hopeless resignation that this is just the way it is and it's never going to be any different. The objective in that case is to help the patient develop better ways of dealing with the conflict, as well as better communication and more effective compromise. Now, if this is a role dispute with someone who's completely unavailable, drug use, abuse, something like that, we're not actually going to be talking about dealing with the conflict directly with that person. We're going to be talking about dealing with that conflict via getting support from friends or aunts or whoever, because that is a relationship that we have to form. Which leads us to occasionally dissolution of a relationship is what happens. So the relationship between the patient and the other person is basically irretrievably disrupted. And sometimes that means you're helping patients make really hard decisions. Divorce, leaving a job, ending a friendship. And I've had all 3 of those and many more types of dissolutions occur. That's challenging to sort of feel like you help a patient get there, but on the other hand, impasse can last for decades, and that's not healthy for them either. So I never suggest getting a divorce, obviously, but a patient often will get there. You know, if they feel like they've tried and suddenly they're opening up about this long-standing conflict and they just aren't over it, they make a change sometimes. And our job is to help support them through that. Yeah?
If you have a patient that comes from a domestic violence situation that in one way or another after they resolve the family, do you still continue with this type of therapy, or do you try to transform the patient to a different level of care, or a more, somebody who is visualizing trauma?
So anytime there's trauma and violence up against binging, I treat trauma and violence first. So if domestic violence is not my expertise, I would refer, I will say I've had one case where I was treating the patient for binge eating disorder, and she was basically pretty quickly into her treatment, she decided to leave her husband, realizing how like it had been just really abusive for her for decades, emotionally abusive. And so I made sure she had appropriate sort of referrals for domestic violence treatment, should that have occurred, because he was pretty abusive. But we continued in treatment. She wanted to do that. So we sort of simultaneously did that. She left her husband, the whole thing. And not shocking, her binge eating got much better. So, but yeah, I mean, the most urgent thing should be the priority, for sure.
I'm thinking about the relationship more parent-child. When you're working with the child in the dynamic, adolescent, and adult, and there's a
was doing groups for Marion, that happened not infrequently, where there's an abusive parent, and it's really awful. So we just basically worked a lot on not helping the patient not blame him or herself for the problematic relationship, and sort of mourning that relationship while simultaneously really looking to the other important people in the circle to build really effective relationships, because it's really easy for a patient to generalize, my mom doesn't like me, therefore no one will like me. So getting a lot of positive relationships in other domains, but yeah, it's heartbreaking. So here are some sample questions you might use in a role dispute. I think you heard Jamie talk about some of these. Like, I'd like to ask you some questions about disagreements you might be having. So she sort of was picking at what disagreements are you having with your dad. Are you and someone else in your life having a disagreement? If so, tell me about it. You might ask for an example of a recent argument or dispute they had. Are you and the other person still talking about this issue, or have you just given up talking? So you're sort of assessing, are they in impasse? Are they at renegotiation? Where are they in this conflict? How have you resolved problems with this person in the past? So assuming that they have some communication skills and that they've been able to successfully navigate other challenges. So how have you done that? Are there people who make this disagreement worse or better? So I think she was sort of picking at the stepmom and the two stepbrothers, like how they were connected to this disagreement, and really trying to parse out, like, is it just about when I spend time with dad? Is it that she doesn't like her step-parent and step-brothers and sister, brother and brother, although it didn't really seem that way, it was more about her dad. So, but still trying to get a full picture. Have you tried to get someone to help you solve this problem? So, for example, have you gone to Aunt Jo and asked for her support, or have you talked to mom, or have you done other things? And what would you like to change about the relationship or the situation? So you could see all that playing out in that role play that you watched about depression. So the treatment goal is assuming that the person you're working with has an interpersonal role dispute. The treatment goals are to help the patient figure out what they want and what they think the other party wants and expects. So help them identify the difference. And in the case of Jamie, who we just watched, it seemed like the dad probably wanted the same thing, or close, right? The dad seemed like a decently engaged guy who just was sort of oblivious to the fact that this was going on. So that's a really positive scenario, because ideally, they're actually probably on the same page. So that's a really good place to be role playing. Another treatment goal is to help the patient develop new skills for communicating effectively with the other party. And you do that role play, building communication skills that we'll continue to talk about in a few minutes. And then to actually practice the skills in session. And then to mobilize the patient who can help, the people who can help bring about a resolution of the conflict. So for example, if there is another party involved, helping the patient sort of get that support going. So for example, if the patient in that role play had been really, really close to her sister, and she and her sister were really, missing dad the same way, then you might even figure out a way that the two of them could talk to dad together, right? Something that might help your patient feel more able to have these hard conversations. So IPT tools, IPT eating disorder tools for interpersonal role disputes, getting really concrete, are to use the strategies to essentially try to resolve the dispute. And how do we do that? Through communication analysis. So get a picture, a data, like a description of the data of this communication. What was said, where was it said, how did you feel, how did that person feel, going through like that. And really listening from the perspective of, if I'm assuming that some of this interaction was a result of differing expectations, and how did my patient communicate her expectations to the other person? And are there tools in my mind that I can then use to help the patient improve that communication? That's how you're listening, and eventually that's where you go. And you even would just say that, right? You would be transparent and go, this relationship isn't getting you what you need. And in part, this is an opportunity now to say, you know, after really understanding some of the conflicts that you guys have had, it seems to me that you're having a hard time communicating, whatever, that you want to spend more time with him. And I understand that because he hasn't always responded really nicely to you. So I'm wondering if we can role play new ways of talking to him about what you need to get closer to what you want with him. Encouraging the expression of affect and then connecting the emotions to the dispute and connecting the dispute to the
Eating.
yay! Okay. Connecting the dispute to the eating behavior, and then using a lot of role play to develop those effective communication skills. It's not unusual to role play every session in the work phase, every appointment. So we're going to watch. I had 2 versions depending on how we were doing for time. Okay, so this is about 9 minutes long, and it is the end of the initial session for a patient presenting with a role dispute in an eating disorder, IPT for eating disorder session. Okay?
I'm sorry, it's the end of the initial session of the working phase?
It's sort of the end of the, it's like the end of the initial phase when you're, because we're in problems, we're describing the problem areas right now. So we sort of backed up, we've gone through the outline of what the treatment looks like, and now we're going back to fill in the gaps of what are these problem areas all about. And so this is a role play that will show the therapist explaining, I think this is a role dispute you have going on, and here's how we're going to work in treatment together to work on that role dispute. So it's really getting at what is the problem area of role dispute.
You?
Good. How are you
Good.
doing?
I'm doing well, thank you. Doing well. Actually, this is the kind of our 3rd session where we're, we spent a lot of time talking about a lot of things. So I thought it'd be really helpful to kind of get a wrap up some of the things we've been talking about and reviewing. And as I've been, like you've shared so much of all the things that have gone on for you, currently and in terms of like catching us up to what's been going on, I wanted to just kind of share with you some of my thoughts about what's been happening with your eating. As I've been thinking about it, I'm really thinking that, okay, here's how I've been thinking about it. You've had a really kind of a long history here with, your parents' divorce, you moved schools, and there's high school, your grandma passes away, your mom marries Bruce, and then she gets divorced from Bruce, you move on to college. Brooke then emerges not only like from like having you take care of her, and you even use the words like you feel like you kind of raised her, and then and now you've really developed a really close relationship with her. I know we spent even last session talking about how close the 2 of you have become, which has been kind of a really nice thing, and also too how your mom has really tried to reconnect with you. And I think the thing that kind of has come up for me over and over again as we've talked, it seems like the times when you're binging and vomiting, or kind of like your binge eating has been at its worst, and the times when you've been most like stressed about your shape and your weight, have really been in and around the times when you've been having lots of conflict, particularly conflict with your mom. Because it really wasn't so much the transition like into high school or the changes that you've made, and even when your grandmother passed away, that was a really difficult time for you. That sounds like you with your dad and with, even with Julia, so we talked a little bit about that, how you'd gotten a lot of support, and that really didn't have a negative impact on your eating. But it's really been, the ongoing distress and conflict with your mom, feeling really frustrated with her, feeling really put upon, with the role that you had to take on with kind of like raising Brooke. And in many ways, it's not unlike kind of what's been going on currently with Kathy. I mean, I know it's kind of a stretch, but in some respects, I mean, think about it. It's like, here's a person who's really, you know, not really mindful of you, not really mindful of your feelings. In many respects, really puts a lot on you, having the boyfriend over all the time.
Kathy's her
You know, even
roommate.
though you were talking about, you know, just the last time we met, how messy she leaves the apartment, that she doesn't really pick up on the fact that it's really frustrating for you. And those are times too when you find yourself, you know, kind of locked in the room, or after she goes to bed, where you find yourself eating a lot. So it seems to me, at least in terms of how we've kind of mapped things out, I think that seems pretty clear that that's been what's involved in, you know, your cheating. I mean, granted, you've obviously you do a lot of dieting and you do a lot of restricting, but it seems the times when it's really been the worst for you have been those times. I'm not really sure as I'm talking about it, if that makes sense to you.
Yeah, no, definitely.
Well, it's pretty clear, it seemed pretty clear to me. I know that as we've been talking about it, kind of putting the pieces together, it seems like that might be one of the things that's really been kind of driving it. Okay, well that's helpful, because that's, you know, as I was kind of thinking about it, kind of going back through, that theme just kind of kept coming up over and over again, you know, with your mom and in high school. I know that even the stress that you were going under when you were transitioning to college, and how she was trying to reach out to you, and then, you know, the kind of disconnect that you felt from her, and so yeah, that makes a lot of sense. So based on that, I think it would be really helpful if we thought about our work together is really centering around helping you kind of manage these conflictual situations more effectively. In particular, I was thinking about your roommate. And I know that we were talking last time about whether or not you wanted to reconnect with your mom. I know that she's been really reaching out to you, and it seems like you've been kind of ambivalent about that.
I mean, like at some point, I guess it'd be nice, but.
Right, because it seems like there's been kind of, you know, a lot of water under the bridge with the two of you. But I know how much you really care about Brooke, and since you know, Brooke and your mom are together, that, you know, obviously that's something that you're really having to think about a lot.
Yeah, definitely for growth, like to have a better relationship.
Right. So I think one of the things that we might want to really get you thinking about is, okay, how can we help you feel more effective in your relationships? Because even still, it seems like you have a really difficult time talking directly with your roommate. And I know that you have a really hard time, even though you've been more vocal with your mom, it seems like that your vocal interactions are more arguments rather than, you know, really finding constructive ways to manage your feelings. And so I think that would be a real helpful thing for us to really work on. The reason why I'm doing this is that, you know, one of the things that I had talked with you about before is that since you're binge eating and is so kind of linked to these conflictual situations, I think what's going to happen is the more that we work on kind of the way you manage conflict and the way that you manage your feelings, it's going to have a real positive effect on your eating. And I think as we start working on this, you'll begin to notice real changes in how you use food. Because obviously food's been a way for you to kind of, and you even talked about it, it feels good, it's a way for you to disconnect, you know, and it's been a way for you, I think even a couple times you mentioned how it really kind of took the edge off, you know, and made you feel a little bit better. And so I think as we help you manage that conflict a little bit more effectively, or some of those feelings a little bit more effectively, I think it's going to really, you know, help with your eating. How's that?
Yeah, I definitely want to be better at all.
Okay, so then this kind of marks kind of the end of our kind of investigation of like what's been going on with your binge eating. And so now we're going to really, even though we've been really working in therapy or treatment together, we're going to start shifting a little bit. And so now, you know, when you come in, I think what we're really going to start focusing on is having you really start doing some of the things outside of here that we can start working on to help you, you know, make some changes. So one of the things I was thinking about first was having you start being a little bit more aware of some of the things that you're feeling. Because it seems like when you're, you know, getting ready to binge eat, or when you're kind of in conflict, it seems like you get, like you described it, that your feelings kind of get a little jumbled up. You don't really know what's going on. You just know that you feel kind of like frustrated, and you don't really know what to do, and you turn to food. So I think that's one of the things I'd like to have us talk about. and then maybe some more effective ways for you to be able to, talk with your roommate, and then maybe we could use that then as a, as a model that you could then maybe we could, kind of help you make some changes in the way in which you interact with your mom. So we'll start, kind of like little at a time, because obviously, Rome wasn't built in a day. So, but we'll take that kind of approach and see if that's helpful. Because I think it will be. And even I've really noticed, even in here, even the last couple sessions, you're making more eye contact with me. You seem like that you're able to have more direct conversation with me, which has really been nice. Because it sounds like that. That was kind of one of the things that you had talked about that it's really been hard for you, in terms of your feelings and feeling really disconnected and feeling really down about stuff. And I'm feeling really hopeful along with you that this is going to be, this is a good path for us to go.
So you can probably see why I chose Jamie is a little more sort of articulate, I think, but that also is an example of what it's like in real time, in real session when you're conceptualizing on the fly, right? There's a lot of, okay, wait, what am I thinking about? Taking a moment to gather yourself, and I like that because it normalizes that experience. So, it's hard. You're not going to have it all sorted out before you're sitting with the patient. So. So, just to sort of summarize where we've come from. So we went through all of the different, we talked about the structure of IPT, and we went through the phases in great detail. Now we're just going back to really hone in on the particular problem areas that come up so that you feel more competent in understanding how to sort of categorize these people so that when you use the tools, you're using the tools toward resolution of the problem in front of you. Okay?
So, from a behavioral perspective that I keep coming back to, like, well, when are we tracking their eating, and when are we tracking how many times they're purging, and when, to like connect it, is that, are we just like, how do you integrate that, or is it not appropriate to integrate it, or because how are we keeping track of like the increase or decrease in symptoms, and because if we focus on one role dispute per week, or that came up, there could have been 10 different ones that I guess I'm trying to put my kind of how I conceptualize with where this is coming.
So I can say a couple ways. So one is you can absolutely ask people to monitor their binges or purges or those sorts of things, and I do that sometimes. I don't always do that quite as explicitly, so it depends on the patient. Like, if the patient sitting in front of me has a base rate of binging of occasionally, then tracking base rate probably isn't as helpful because it's a little more, like,
So what if you have like a young adult who has bulimia?
Right, so in that case, I would be asking them when they start the session with me, like, did you have binges during the past week, and did you purge, and like how many times do you think you have a sense of that, and if they're tracking it, then bring the tracking in, so that you can say, I'm noticing a decrease in the number of binges you're having, or I'm noticing a decrease in the number of times you purge. If you're doing a group, absolutely, when I've done group protocols, there's absolutely a weekly check-in of mood or binges. So I do monitor it, but again, I know this sounds sort of non-answering, but when you're with a patient, you sort of have a sense of if tracking their binges, like self-monitoring wise, is going to be too focused on the eating disorder and not enough focused on the interpersonal stuff. And ultimately, I'm really focused on the interpersonal if I'm using IPT. So I do care about how many binges they've had, but I care much more about the work they're doing in their interpersonal relationships in the course of our treatment together, which may be why IPT takes longer to show results on the eating disorder symptoms, because the changes that you're making are really more focused on the triggers to the binging rather than the binging itself. So yes, I do ask patients about binges, I might say something more general, like, you know, have you noticed a change in your binges over the past week? Or, you know, what's been happening with your binges lately? Have you noticed that there's any reduction in them, or have you noticed times when you thought, oh, I might have binged there, you know, a few weeks ago and I didn't, or so I might sort of get at it that way, but I don't spend a lot of time assessing that. So in another part of this role play, that this is a training, and you have the website, you just have to log in, it's a free training online. But I think there's one session where he says, you know, I noticed the number of binges you've had have come down, and so in like the counseling center, they gave like just a handout that said, you know, how many times have you binged this week, how many times have you purged this week, just like a questionnaire. So you could certainly do something like that. Okay, so we're going to move into role transitions. So the role transition is chosen as the problem area when the onset or maintenance of the symptoms is associated with difficulty coping with changes in their current life circumstances. So this is conceptualized as moving from one social role to another. So student to employee, military to civilian, single to married, non-parent to parent, employee to retired, married to divorced, those sorts of transitions. Even when these changes are positive. So in theory, getting married is a positive thing. In theory, having a child is a positive thing. That doesn't mean it doesn't have any impact on the patient's mood or eating behavior. Oftentimes there's, like, for example, changing to parenthood, right? There's sleep disturbance, there's marital changes, there's job changes if you're a mom and has to go on maternity leave. So there's all sorts of transitions happening just with the idea of just with giving birth to a kid. So there's lots of work to do there. Another place, I'm a health psychologist, so I work with a lot of people with chronic illnesses as well. So the diagnosis of a chronic medical condition is a very big transition. Whether it's MS, cancer, any long-standing chronic disease can be a real life transition for someone. Caring for someone who's dying. So becoming a caregiver is a big life transition for people. Obviously retiring, marriage, childbirth, poverty after the death of a household earner. So if you suddenly change social status because the person who earned the money in the house is no longer, separation or rejection by a lover, becoming a refugee, there's all sorts of real life transitions that happen to people all the time.
So when you have like a lot of overlay, you can go transition. So thinking of the instance of like an oldest daughter who's the mother and like is now terminally ill, where the family might be pressuring to take on that caregiver role, and is also taking that on, but maybe not wanting to, and then you have grief of the ongoing death.
Yeah. So in that scenario, what I would be thinking about is that there's a role dispute with the family member who's doing the pressuring to take this caregiving role, and a transition, because if the patient is taking that role, then she's changing her life or his life, and I would be addressing both of them. With the one that is the most sort of likely to be resolvable, so if I were hearing that one, the dispute is probably a place we could make inroads a little more quickly than adjusting to the role of your mom dying. So, you know, having a conversation with your aunt that essentially says, look, I'm going to do this, but you pressuring me doesn't help me, like in a nice way, is sort of the end of that role dispute, right? You can sort of address it at least in a very direct way, and then you can move on to the transition.
Any difference in how you track binges if you have a chronic illness that is impacted by the binges, like diabetes or yes or something?
Difference in how you track binges, like
Considering health risks, if you feel like there's certain instances where you might have more urgency behind. So I think one of the differences I was thinking about, Christina, when we were talking about tracking purging behaviors and restricted behaviors, is there's some urgency in the medical component, which isn't as present with the binging. I was wondering if it was chronic.
so absolutely it can be. In the early phases when I'm doing psychoeducation, and the biopsychosocial, environmental, cultural thing, I'm talking about that, right? And rarely have I met someone that has diabetes that doesn't know that binging on sugar is bad for their diabetes management, right? So I try not to sort of like stay there. I just sort of mention that obviously you probably have, if you're a patient, like you probably have concerns about what the fact, you know, what this does to the diabetes, to your diabetes when you're binging on ice cream at night. You know, I'm sure that's something that's been on your mind. And so hopefully over time, as we continue to address the factors upstream of what's causing your binging, that hopefully that will have a positive effect on the diabetes management that you're working with your endocrinologist as well. So I just might sort of link it, but I don't stay there. I mean, if they're going into diabetic shock or something, then it's a different story. We need to be a lot more collaborative and potentially inpatient care with diabetes management. Did I see a question over there now? So just this last point, so sometimes the role transition is chronic, like once, you know, if the homeowner or if the earning member of the family is gone and the person left was a stay-at-home mom, for example, for 2 decades and doesn't have a lot of job skills, their life status change is probably going to persist for a long time. So we have to be aware of that and not sort of feed into unrealistic expectations, and I really just, that's just something to be aware of. That's with any case you're working with out there. And then remember that sometimes situations don't improve even if we really hope they do. And so that's just, again, something for you to be aware of when you're treating patients. Sometimes life is really challenging, and our goal is to help as much as we can reduce the eating disorder behavior by addressing interpersonal functioning within the context of their real lives. So the treatment goals for role transitions are to help the patient recognize that they're experiencing the feelings related to the transition of sadness, anger, confusion, powerlessness. So giving them some emotion language around these transitions, and then examining what might be positive about the change. So going to poverty, probably not a lot of positives, unless there's a case where, you know, the breadwinner was also a demeaning, abusive person that's suddenly out of his or her life. Like, you know, very gently and appropriately, you might help the patient identify that, okay, well, being out from under the thumb on an abusive person who brings in the money, he's going to have a few emotional benefits potentially, right? Even though life is going to be different and more challenging in this new financial state. We want to help the patient learn skills necessary to manage change, because the change that you are going through with your client and working on is by far not the only change they're going to experience in their real lives. So arming them with the tools and saying, now you know how to navigate changes a little bit differently can go a long way. And then find the support to make the change easy. So again, building other sources of support outside. So what do you actually do? So you relate the symptoms that they're experiencing to the difficulty coping with the recent life change, making that link, making that connection. And then you help the patient to mourn and accept the loss of the old role. For a new parent, it's okay to talk about missing life before a kid, right? That's a really big life change, and a lot of parents feel immense guilt in even mentioning that they missed life without the kid. But it's okay to talk about that. It's okay to give them a space to talk about mourning that, while at the same time reviewing the positive and negative aspects of the old role, right? There's probably some other things that they don't miss about not having kids. And then exploring feelings about what is lost. And then talk about helping the patient do the same about the new role. So there are good and bad things about the new role as well. And let's talk through those. Let's explore feelings about the transition itself. Let's talk about opportunities you might have in the new role that you didn't have in the old role. And discuss skills that the patient has to effectively succeed in the new role. And then, of course, developing social support in the new role. So here's some sample questions. So tell me how you're feeling about this change. Tell me how the change itself is impacting you. What are some positive aspects of the new role, and what opportunities might you be afforded as a result of this change? What are some of the expectations you have? Tell me about the skills you have that will help you succeed, and what skills might you need to better develop to be effective in this new role? How might you begin to create a social support network in your new role? Let's set a goal of one thing you can do to build your social support this week. So we're going to use postpartum because it's a really obvious role transition one, and I have a DVD, and if I know how to use this, we're going to be good.
I got a call from Dr. Ian. She's over there.
Can you hear that?
No.
So, tell me about you.
Well, I think you're, because I was screening.
Can you hear it? Not really. You told me that volume button was the one, but I don't know.
I'm still kind of, I don't know, I don't really understand
Can you hear it now?
why I scored the way I did, I guess.
Magic touch.
I don't really know, I don't really know how I'm feeling lately, and I don't know, I guess it just seemed like a good idea. I'm feeling overwhelmed, I think, so.
Okay, so you went through the screening, and
Yeah.
6 weeks usually is when I do that.
Right.
What was your reaction when she told you that you had a high score and suggested you had the visits?
Well, I was very surprised. I mean, I've never had problems with my emotions. I mean, I've never had that before. I've always been very even keel, and able to control myself, under stress, things like that. So I don't really understand why all of a sudden it's a problem. And it does seem like it's been sudden. So.
Tell us more about the story. When did you first start noticing it? When were things different?
I think it was probably, I guess I would place it right after Grace was born, if I really think about it, I think it was probably, I think it was a couple months before that. I just started to feel a little uncertain about certain things because, we planned to have Josephine, little Joe was we were definitely going to do that. We've been married 5 years, and.
Let me reference that, because I'm afraid if I don't take some notes, I'm probably going to forget some of this.
Oh, sure.
If I take some notes.
No, not at all, not at all.
So far away.
Okay.
So Grace and Josephine.
Yeah, so, and, Josephine is 5 years old, and she is a handful, and she's adorable, and I love her, and Grace was a bit of a surprise, we weren't really thinking, it wasn't a bad surprise, but I didn't think that, I had kind of been focusing on, I do web development, and I have a bunch of freelance contracts around town, and, I've been doing fairly well, I have Gray Lights, and Textiles is developing a website, and, I had a number of contracts, and, when I found out that I was pregnant, I realized, I probably can't, keep up the business the way that I would like to, and, so I pulled back on certain things and bid on other things, and I got everything wrapped up, ready, since, my income is decent, but it doesn't really, I couldn't keep that and do daycare. We decided it would be just more economically beneficial to the family if I took care of the kids, and so, I don't know, suddenly it feels really hard.
So it almost sounds like you were anticipating that transition towards the end of your pregnancy. So
I mean, you know, I just didn't have to go anywhere anymore. I didn't have to, you know, I didn't have to make the calls, you know. I did a really good job covering the bases, but it was like, it was too good, you know. There was no, I mean, I feel funny leaving all that behind.
So let me ask you a little bit more about the pregnancy experience and delivery and stuff. Did you have any complications during pregnancy? It was pretty smooth.
It was pretty smooth. You know, I'm good at being pregnant. That's something, you know, that I learned with Josephine. I just, you know, I didn't have morning sickness. I didn't have any. I was very physical. I was able to work out until the 8th month. You know, taking it easy, of course, but you know, I mean, I was able to keep my routine, keep my schedule, and you know, and the labor was 6 hours with the first and 4 hours with the second. You know, I mean, I was built for this, so you know, it definitely wasn't a problem. You know.
And it wasn't the girls' health.
Oh, completely, yeah.
One of the things, are you breastfeeding at the moment?
I am.
And how's that?
That's fine. It's, well, I mean, it's not as, sometimes it's a little difficult, you know. I mean, Gracie isn't difficult. Yeah, I don't know how to describe it exactly, but it's different than it was with Josephine.
Can I press you a little bit more on that? What is different? I know you said it was difficult, but I would push a little bit more. What seems to be difficult? How would you put that in words?
I'm not sure. I remember, you know, Josephine feeling more content. I just did not. I mean, there was this like rush of mother love, you know, and this time it feels frustrating, you know. I feel frustrated, and I find myself being annoyed with her for taking up my time, you know, and then I feel annoyed that I don't have more to do, and then I feel there's all this frustration, you know, and I just don't understand where it's coming from. I made all these choices. This is what I wanted, you know. I put all of these blocks into place, and I don't understand why I'm not fine.
Frustration is a really key.
Very much so.
Do you have a sense about what you're frustrated about?
It just doesn't feel right. I don't know how to characterize it. It just, sometimes it feels, and I would never say this to anyone else, but I mean, sometimes it feels like a mistake. And then I feel so guilty. And, you know, I mean, there are no mistakes. Life doesn't give you mistakes. You don't do that. You learn from everything. And everything happens for a reason. And I tell myself this, and I still feel like crap. And I don't know what to do.
So let me go back for just a minute and kind of round out some of the potential difficulties or stresses that you're having too. You mentioned especially a sense of frustration, annoyed, that guilty feeling. If you were to put words to your mood, how would you describe it?
I don't know. I guess just I feel irritation a lot. You know, I find myself kind of upset. You know, it's just, you know, why is this my lot in life? Why is my husband helping me more? Why won't the TV work? Why is the car breaking down? You know, I just feel myself getting really angry about so many things.
Can you give me a specific example about a time like that?
Last night, you know, Gracie kept getting up, and I mean, she doesn't. Oh, do you need like that?
That's all right. Let's go over a couple of
It's okay. Okay. But she kept getting up, and she does this thing where she's just a night owl right now, and so I guess she wakes up and she doesn't mean anything, but she just yowls, you know, and she just wants somebody to come and hold her, and you need to be. She knows when you're falling asleep or when she wakes you back up again. And, you know, she just needs somebody with her all the time. And I am speaking to you through a fog of sleep deprivation right now because my husband would not get up.
So
He would not. And his schedule today was not that hard. He's a kitchen manager, and so he was only at the restaurant for 4 hours. He's home now. She couldn't help to.
Tell me more about what you did in that circumstance. So she's something overnight. She's kind of making noise that she wants attention. What happened? What did you do?
Well, I was laying in bed and I could hear her, and so, I mean, the thing is next door, so it went off. And, you know, I heard him roll over, like he was just not even going to acknowledge the situation. And, you know, so I touched his arm, and he didn't, he just pretended to sleep, and I know he was pretending. And I just sighed, and I helpfully sighed, and then I went into the bedroom, and she was there, and she was crying, and I picked her up, and I held her, and with a rocking chair, and I rocked her, and as soon as I would kind of fall asleep and stop rocking, she would start screaming again, and I know, he could hear the whole time, he could hear everything, and he knew we only had a 4-hour shift today, and that apparently didn't matter, because he's a man, and so he doesn't have help, and,
It's a good example. The illustration of what I want to go back to too, because I can sense even as you're talking about that, the frustration in your voice and being pretty angry is what I would say. I don't know if that's your experience.
yeah, well, I mean, I just feel like, you know, just because, fine, you know, fine, I'm not an executive anymore, I'm not, going off to work every day, you know, we stopped at the office, but still, that doesn't mean that I get to be sleep deprived constantly. You know, that doesn't mean that I am only a nurse to my children, you know. I mean, I just don't, it feels so unfair to me. And I get very irritated and apparently depressed.
That's a great example. Let me digress for just a moment. One of the things that we found really helpful in therapy in this particular type in our personal psychotherapy is talking about relationships and support that people get. There's already a couple of things that are emerging. One is the big transition for you, especially stopping work. Going through having babies is a big transition in any case, I think. And I'm sensing some conflict between you and your husband as well.
Yes.
So this kind of interpersonal conflicts, and those are very common, by the way. I think these couples that people get workload. Sometimes that happens with the first child, sometimes it happens when the second comes along. So it sounds like those are two things that we got to put on the front burner to discuss in more detail.
And he was pretending to sleep. Maybe he did. Sorry to interrupt. Go ahead. Honestly, he really.
How relatable could that be? I was watching this with my husband sitting in the room the first time, and I'm laughing, and he's like, what? Because he's reading the newspaper. Okay, so let me go back. Sorry. Do I just hit laptop, right? And then both. Yeah, that's right. Why is it? Okay, thank you. Okay, so obviously in that case, major transition going on and some role disputes. And those are normal to go together in her case. In this case, this is a DVD from the IPT Institute. Scott Stewart is the clinician you see there. I think he's a really great therapist. His style is really personable and funny. You can buy this training DVD through the IPT Institute. And this was created in 2010. So, sort of to wrap up, what I wanted you to just see what a role transition would look like sitting in front of you. The tools that you would use are the same tools we've been talking about all along, the communication analysis, the role playing, the affect. He's already helping her with affect, right? He's giving her and pressing her a little bit on the language, like the frustration was very apparent, but then other feelings too. And so he's already building her affect awareness in session, and that's pretty early on. So we've done role disputes, we've done role transition, we have grief and interpersonal deficits and life goals to go. Let's take 5 minutes now. Does that seem right or no? Yeah? Okay. Let's take 10 minutes. So 3:45? Yeah. Really common. So like
this is kind of a common case. Do you notice that people kind of don't want to talk about it as much? They're like, oh, it's common. They kind of brush it off. You know what I mean? Rather than saying like, oh, I'm feeling all these feelings, and like how as a result, like you were saying earlier, they feel like there's no resolution, so they just don't do anything.
I think so.
Yeah.
I mean, I think most new moms feel something like that.
Right.
So it'd be really easy to be like, that's not even worth talking about.
It's just normal.
It's just normal.
Everybody goes through it.
But again, if we're talking about in relation to eating disorders, I would always go back to if there's an exacerbation of binging, and later in this DVD she talks about weight gain, just postpartum weight gain anyway. And so I would be saying like, okay, well, whether every single mom feels this way or not, we're really talking about the